Good morning, everybody. I'm Dr. Mark Hyman. I'm the director of the Cleveland Clinic Center for Functional Medicine, and we're here today for grand rounds on pain. Hopefully, it won't be too painful. I'm really honored to bring one of my colleagues and close friends, Henri Roca, who's he's one of the leading thinkers in how to address pain through the use of functional medicine. He's done so at the VA in Little Rock, Arkansas, and has found extraordinary benefit using a systems approach in groups with very little medical intervention, is having extraordinary outcomes. And we're going to hear about those outcomes today. He's a family physician. He's been involved with the consortium for the Academic Centers of Integrative Medicine in many ways. That's where I first met him. And we're really honored to have him here today to share with us his insights about how do we address pain through the use of systems approaches, groups, and functional medicine. Welcome.
Thank you very much, Mark. I am honored to be here. Thank you all very much for being here. I had no idea when I first arrived at Central Arkansas VA that this was going to be such an important piece of my life's work. It is a great honor to serve our veterans. And more people are going to be seeing more and more veterans, so it's really important to sort of understand how veterans work and how we can use functional medicine to help them get to a better place of functioning. So I don't have any disclosures. And we'll look at these objectives. We're going to talk about veteran population, how that may be a little different. We're going to explain the concept within the VA of whole health and how we apply that. We'll look at ways to change the conversation around pain, and then look at the reasoning behind self-care. And you'll see that self-care is a critical piece of this process as we move through. So when looking at the veteran population, there are some things, and this is a very large study, 400,000 people. You can see most of them were in their 30s, which means they were from our recent military actions. They're mostly men, they're mostly white, they're mostly educated, they're mostly single. But when we get a little further down, you can see a very high level of service-connected disability, and we'll talk about what that means in just a minute. In addition, multiple pain diagnoses, that's not surprising, but obesity at a very high rate. You know, only recently did our states move to 40% obesity, and I believe that's Louisiana and West Virginia, and our veteran population who have pain. 40% obesity population based in those two states, with the rest of the South moving toward that goal, as if it were a goal. And then mental health diagnoses. The comorbidity is extremely significant in the veteran population. Mood disorders, PTSD, anxiety, substance use, and then smoking is also highly prevalent in pain population. When you sit down and when you adjust for age, gender, service-connected disability, you could see these things emerge significantly. So 1.76 odds-adjusted ratio for service-connected disability, for smoking, for mood disorders, for PTSD. And so when we're working with our veterans who have these challenges with pain, we have to really incorporate these components into that plan of care. They are not separate components. It is a unified kind of approach. So, service-connected disability. Now, that means that our veterans come in, and of course, you know, we have agreed as a country that we will help them if there are these disabilities. So this is fibromyalgia specifically, and this is the way that it sort of works. When you look at fibromyalgia, the definition is tender points, fatigue, sleep disturbances, stiffness, paresthesias, headache, etc. Not a surprising kind of a thing. 10% disability, which means that they get a payment every month that is 10% of the total amount that you would expect for a person to be able to earn if they need medication for control of their fibromyalgia. Now, what does that mean for a functional medicine perspective when our goal is to help them heal without medication? Immediately what we're doing is we're taking away someone's income. And that is a key confound when dealing with veterans within the VA. If a person is more severe, then that individual has exacerbations present more than 1/3 of the time, and they get 20%. Now, if they're 40%, then they are refractory to treatment. And so pain continues despite being medicated. When you're doing pain scores, what do you think that means for pain scores? They are very resistant to movement. And so when we're looking at outcomes, we can't really look at pain scores very easily because there is a confound about keeping pain scores high. If you go a step further, a court recently ruled that chronic pain independent of a source is now also listed as a disability. So you don't have to have a source for it. You just have to experience pain, which is a self-reported experience. And so when dealing with pain, it's really quite complicated within this kind of a setting, because there are many things that drive people to report experiences that may or may not be supportable by understanding underlying causes. With that, the VA, and I think you all will get these slides, right? Slides will be available. So you can click on all of these links. The VA is doing amazing research within the field of pain. A lot of the research coming out from population basis is from the VA. And in Central Arkansas, we're involved in 2 studies now. One that compares an interprofessional team with a clinical pharmacy intervention, and another that compares a whole health or an integrative medicine team with a usual team and with cognitive behavioral therapy. It'll be years before those trials reach its conclusion, but that's the kind of research that's being funded now by the VA, DoD, and NIH. One of the interesting studies here is this one about acupuncture. And so with acupuncture, we've shown that electrostimulation increases stem cell activation, which gets to be really important when we're talking about fascial remodeling. So whole health. Whole health is the VA's term for holistic medicine. We can look at this definition and we can see functional medicine sort of written through it, right? Proactive, patient-centered, predictive, personalized healthcare. That sounds like the definition of functional medicine. But it's done purely with a health coaching model. So everyone approaches this from a health coaching perspective. And it allows the veteran to return to wellness. The measure of success is their ability to live a value and mission-filled life. Now, doesn't that throw on its head the idea of what healthcare is designed to do? Very often we think of healthcare as designed to suppress the experience of symptoms or to somehow do secondary prevention from negative outcomes. But here we're switching that and we're saying that the idea of successful treatment is the ability for people to live the life they choose without their specific symptoms impacting that. It's a significant different change in focus. And this is being rolled out across the entire VA actively and with a lot of support. So you see the Circle of Health. The Circle of Health was first published by Dave Rakel, and the Circle of Health has several components. The patient is at the center, or the individual practitioner. Like, we are at the center with the patient, but the patient is driving this process. This process is not paternalistic. In no place do we tell the individual what it is they need to do. There may be many things that we think the individual should do. There may be an entire list of actions that we think might be high yield, but the question is, what are you willing to do? Where are you willing to begin? And I'll tell you, one of the biggest learning experiences of my life was going through seeing a patient having a long list of things that they could do. And when I asked them what they were willing to start to do, the individual said, read the Bible. And that was it. That was the outcome of that visit. That the individual left saying that they had agreed to read the Bible. Their spirituality was the most important thing, and their illness had taken them out of their relationship with God, and getting back to reading the Bible was most important. And I had to sit there and say, that is a valid outcome for this amount of time that we spent, which was not part of my medical training, to have as the outcome that someone was going to read the Bible. They came back a month later, they had read the Bible, and they'd done 3 things that they hadn't been ready to do at the moment of the visit, but they knew could be done. If a person has success in any one thing they choose, they're more likely to pursue other things they might not have been ready to choose at the moment. And those things are much more sustainable than the things we tell people to do. So this whole health approach sort of throws things on its head again by saying that the patient is at the center. They get to choose their interventions among that realm of possible interventions, and then they can choose other interventions as you go forward. So that's the me in the center. The patient is sacrosanct. Around that is this idea of mindful awareness. absolutely essential. We know that individuals have to be present in the moment and understand the messages their body is giving them, and also really be present in a specific way so they aren't pulled by their thoughts, feelings, or memories into other kind of catastrophizing situations. This is especially true of our veterans who have trauma, whether it's military sexual trauma or PTSD. Very essential that they have mindful awareness. And so that skill is an important skill, a foundational skill that we reinforce continually in our program. Around that are the realms of wellness, and we'll go through those in just a second. But those are the opportunities for self-care. We can think of those as the bottom of the matrix. These are all of the things that people can do to enhance their health, and that is the go-to place. That's the first place. Surrounding that are the full realm of interventions, conventional and complementary. Oh, sorry about that. So the matrix is the way we think about functional medicine. And functional medicine at its core is the ability to identify patterns so that we no longer think of symptoms as the thing that needs to be targeted, but we look at how all symptoms, all behaviors, all review of system items that are positive, how those things are grouped together in a series of patterns and how those patterns relate. Ultimately, the bottom of the matrix are those health-related behaviors that can either determine whether or not a person has some resiliency or be the basis for the drivers of these individual patterns. And those patterns of dysfunction may be as varied as things like gut function, detoxification function, inflammation, challenges for chronic illness, biomechanics, neurotransmitters, hormones, those kinds of realms. These are the organizing principles that drive disease. Our challenge in functional medicine and in whole health is to identify the patterns that drive disease. And by working on those resiliency factors at the bottom of the matrix to actually help people come to their best place of health. Yes, we're going to go through them relative to whole health in just a second. And so when we look beyond that, what we see at the VA and what has been shown by research in behavior change is this idea that, when you're watching a person and helping them be accountable, then people are more accountable. We know that individually, if we have personal trainers or we work with any kind of coach of any sort, when someone's helping us be accountable, we'll stay on track. And when we're not watching them, then people go back to their bad health behaviors, right? So community subsumes everything. We can't work with an individual without recognizing that they exist within this larger social and cultural context. And I'll tell you, in the state of Arkansas, which is 46th in our overall health rate in the nation, right? We're down there at the bottom. When we have our veterans come to a better place, and then they go back out into the community, it's very easy for them to backslide. So the idea of maintenance groups are essential. So when we talk about the bottom of the matrix, we're talking about these realms of whole health. So recharge, that's what you do for rest and relaxation as well as sleep. Working the body, that's all about what you're doing physically, whether you're taking medications, whether you're taking supplements, whether you're doing any kind of movement, cardiovascular, flexibility, or strength training. Working the mind, the power of the mind, so your resiliency to take in new ideas, but also to work with thoughts, feelings, and memories. The idea of surroundings, so how is your landscape? It's really hard to ask somebody to walk if they're in an unsafe place. So how is your house? How is your community? How do you fit into that? The idea of friends, family, and coworkers, so the relationships that people have with the people who are closest around them. We know that there are 3 degrees of influence that your friends have. So you influence one person who influences another person who influences another person. If you're optimistic, that optimism flows through your network of friends, even if you don't know the individuals. So the network of support is critically important. So personal development, what a person wants to do with their life and how they want to evolve. These are all resiliency factors, and very importantly, food and nutrition. A critical piece of building health for the future. These are the bottom of the matrix, and these are the realms of wellness within the whole health model. So the Defense Veterans and Pain Pain Rating Scale is what we use both at the DoD and the VA to get a sense of pain. So it is a subjective measure, but at the bottom, you'll see that there are these descriptions, and the descriptions are critically important because they speak to function. So in order to get the best measure, we ask people to look at those descriptions and rank it accordingly. And this gives us the opportunity to quiz people and say, is it really a 10? A 10 means you are in bed, curled up, the lights are off, and you're not doing anything. If you're in front of me, by definition, it's not a 10. And we wanted the individual not to have less pain, but to rank their pain in a way that we can more reliably see impact over time. So this is a measure that we use. Now, within the VA, there are these guidance documents that help define how we're going to use integrative medicine and functional medicine. And one is the Comprehensive Addiction and Recovery Act of 2017. That sets up flagships. Those flagships are designed to be locuses of distribution, of dissemination of this idea of an integrative approach. And it requires an integrative pain rehabilitation model for VA facilities. The other is a specific memo that requires VA facilities to have 8 specific kinds of integrative medicine modalities available to their veterans, whether they have them on site or whether they send them out. And that's just happened, I believe, last year. And that's the Executive Memo 1137. The Opioid Safety Initiative is long-standing. The VA used to be the leading prescriber of narcotics, and now we're one of the lowest prescribers, having taken people off over the course of time. Not always easily, often precipitously. So people are left with their chronic pain without the use of narcotics. And so we really need to approach that, and this rehabilitative model helps to do that. And then finally, the JCO requirements in 2018 said you no longer need to use pain as the 5th vital sign, which was one of the drivers of this entire process. And so there's more freedom in how we use pain measures over time. We want to reverse what can be reversed. This is, in essence, functional medicine. How do we look at potential causes that people may have not seen before? How do we bring a person back to a better place of balance? We want to enhance self-care. Chronic pain is a full-body, brain-based behavioral disorder, and so self-care is essential. We want to increase veterans' management of setbacks. So chronic pain is a perpetual issue for the individual, just as PTSD is. It's not something that is often removed. It's what you learn to live with, and there will be setbacks. For our program, we work with these individuals over the course of their life. And then finally, we will use medications safely and prudently. And so we know that narcotics are not in vogue and people are being taken off of narcotics. And now what is the 10th most prescribed substance that we have? Gabapentin. So the gabapentinoids. And it's just a matter of time before the dark side of gabapentinoids comes to its place. And we can already see part of what that's going to be because they work by preventing pruning, right? By preventing the growth of new neuronal connections. What does that mean? Often our veterans report memory challenges when they're using these medications. That's going to be the next reason to not use those medications. So even though that is sort of the next go-to place, ultimately we're back to self-care. We're back to active engagement, active coping as a way to work through the challenges of chronic pain. So this is not only an individual-based, proactive, patient-centered approach, it is also a population approach. Within the VA, there is reimbursement on the basis of the number of people that you are responsible for in your regions. So for usual patients, primary care patients, it's about $3,000 to $4,000 a piece, and that covers every single thing the person needs. So it is a population-based approach. As we go through how the program works, you'll see the focus on population basis as well as individual basis. So this is the Integrative Medicine Patient-Aligned Care Team for Pain. A PAC team is our patient-centered medical home, and it's made up of a provider, a nurse, an LPN, and a front desk person. We call them MSAs, and that's our team. So our team provides consultative care for any individual who comes to us from any source across the facility. across the region because we have remote clinics that serve most of the state of Arkansas. They come into Little Rock. And we also provide primary care to many of those patients. So we're both a consultant and we're a primary care provider. When we are a consultant, we still do everything that a primary care provider would do. So when we're dealing with pain, we can't take pain out, hang it outside the body and say, we're going to do something for this. We have to see the whole person, which means that our primary intervention may be around diabetes, or it may be around some inflammatory condition or some chronic illness. And that may be what that may be a key part of our treatment plan. And we are empowered to do that, even though they have another primary care provider. If you say the same thing over and over, put it in a group. How many of you say the same thing over and over and over and over? If that happens, then it is a group process that's going to be most effective for that process. Critically, a person in a pain hole. Does everybody know what a pain hole is just by the description of it? Everybody have an imagining of what that is? A person cannot see anything except their pain. When you ask them what's important, nothing, because I have pain. What do you want done? I want you to stop the pain. Every response is about pain. And we have a specific tool called the personal health inventory that goes around those realms of wellness. We ask the individual where they assess themselves. We ask them where they want to be. We ask them why they are there and what they want to do or what they think they can do to get to a better place. And when their answer is, I'm at a 1, I want to be at a 4, on all of those realms of wellness, and their reason is pain, 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 pain. And what do you want to do? Can't do anything because of the pain, 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 pain. I see some smiles. It is a familiar experience. That's a pain hole. If a person's in a pain hole, they can't hear much of anything else you say. So it's got to be changing the conversation to get them out of that place so that they can see something else. Health coaching does that. Telling the story back to the individual, that idea of finding out that individual's full history, which is a key component of functional medicine. It's how we assess these patterns by looking at how they evolve over the course of life. Family history gives you an idea about the genetic propensity. You look to see uterine history to see what may have been turned on for life. You look at early childhood history, middle, late childhood, early adult history, late adult history. All of this is a critical piece of our history of the present illness. It's not just what happened in the last few months. And the amazing thing is when we let our patients just speak their story, you know how long they speak. If we don't even interrupt after 27 or 22 seconds, 90 seconds, which is sort of sad that they've come to this place of training that their story is 90 seconds long because they know what we expect to hear from them. Their story is a lifetime long. Understanding their story, being able to tell them back their story, looking at all of the interconnections that ultimately create their current situation is an important way to reframe them out of this pain hole. And then finally, group process, where group members can speak truth to each other in ways that we as providers could never speak to individuals. All of this helps folks get out of this pain hole. If a person isn't engaged, you can't force them into engagement. Sometimes it just means that they need to wait until they're ready. And one of the best ways to get an individual engaged is to hear stories from other people who were in that same situation. They suspended disbelief, were willing to engage, and got to a better place. When they tell their story, people are like, well, maybe there's hope for us. There's a specific video on the web. You all may have seen it, Arthur's story. Anybody seen that? I can send you the link. It's about an individual who had been a paratrooper, hurt his knees, hurt his hips, got to be very, very large, walk with canes and braces, in wheelchairs, I mean, not very functional at all. And by doing yoga and by doing nutritional intervention, he was able to lose 140 pounds, got rid of his braces, got rid of his canes, was running, standing on his head, doing anything that he wanted to do, completely transformed, showing individuals that story so they can see the transformation over time. And this took the individual 10 months, not long, but they worked. Showing them that story gives people the indication it is possible for them. So that idea of reframing is very important. Now, when people come into the program, they self-select, right? So this is a group-based program. They come into an intro group where they choose whether or not this program is for them. And one of the first things we do in that group is to reframe the concept of pain. So for that group, we'll say, does everybody here have chronic pain, right? That's their ticket in. We presume they're going to say yes. People say yes. The next question is, does anybody think their pain is the same as the person's next to them? No, very rarely does anybody say yes. But I mean, like one time in all these 5 years, but that was a different issue for them. So they recognize it's different. So I say, okay, then what is this pain? Is it a thing? If it's not the same, we call it something, we treat it as if we can do something to it, but yet it's very different for each person. And then I'll ask them, say, okay, well, tell me some of the places you experience pain, right? And they show up, all kind of joints, muscles, the whole body. I mean, it's just the gamut. And I said, well, let's look at one of those specific areas. And so we talk about joints, and we talk about all of the potential contributors to pain within that structural unit, right? Tendons, ligaments, nerves, muscles, joints, joint capsules, etc. And so not only, even if you say, I have knee pain and you have knee pain, there's no guarantee that it's coming from the same place. And then we have the conversation, which starts this exploration of functional medicine that says, so what makes it worse for you? And people will throw things out, right? It's worse with no sleep. It's worse with stress. It's worse with weather. That's a common thing. Some people will get that it's worse when they eat different kinds of foods. So they start throwing out their experience. Now, you'll see that this is a different way of approaching the issue because this is a eliciting kind of a way, right? I'm not telling them what's up. I'm eliciting from them their experience. So this is a health coaching approach to understanding this concept of pain. I'm not lecturing to them. I'm asking them to give information from the basis of their experience and then filling in whenever they don't bring up something or clarifying things if their information may happen to not be as correct as it could be. But it's really coming from the wisdom of the group. So you start this idea of bringing these things out instead of giving it to them. If you start giving people information, like even today, after a while, you'll be like, okay, I'm full and I can't take any more and I'm good. That's the nature of how we receive information. But yes.
Frame it. My understanding of your work was that you don't actually initially see patients one-on-one, and everybody comes in a group. Is that accurate?
Mm-hmm.
Yeah. I think this is important.
And we're talking about the intro group. Okay, so the intro group is their entrance into the process where they get to opt in or opt out. And we go through this concept. And then we're going to get into the actual nature of the groups in just a second. And so, we're talking about the drivers of pain. And this is where we bring up, if you drink alcohol, you can be worsening your pain. If you smoke, you can be worsening your pain. If you have diabetes, if you have any inflammatory condition, if you have chronic illness, you can be worsening your pain. If your gut doesn't work right, if you have deficiencies, all of these things can drive your pain, and all of these things are reversible. Why suffer from reversible pain? If your glass is already half full with pain, then why keep filling it? That's something that you're volunteering for. We're here to help understand what that might be and to help give you suggestions about what you can do so you don't have to keep filling the glass to its overflowing. And so that's an important concept as we go through that. And it's really it can be an earth-shattering moment, but it's an eye-opening moment for these folks who've never heard this conversation before. In the past, the entire conversation was about pain as a thing, and here are things we get to do to it, as opposed to look at all of what you can do around this concept. Very important. Now, they will choose to opt in or opt out of a 9-week group. That is their next step. They choose whichever one that is, however far in the future they choose it to be, or however near they choose it to be. It's a 9-week group. We show this to folks, and And we show it to folks because we point out that pain is an experience. And we talk about how that experience emerges from thoughts and feelings and memories, past associations with sensation. We talk about the biomechanical pieces that could be off kilter, whether that's leg length discrepancies, scoliosis, differential strength across the body, whether that's fascial distortions, whatever it may be. We talk about psychological components, talking about anxiety and depression and PTSD and MST and coping and resilience. We talk about the medical components, and these are those realms of functional medicine, different things that medication cause, different drivers for pain. And so people get to see that pain is not a single thing, that there are many places of intervention. And for our veterans, for our patients, this kind of display is really important. It takes all of that conversation and it says, wow, look at everything that goes into this. We've never had this kind of approach before where people are looking at all of these kinds of things. We really focus on groups. That's absolutely critical. And there are some pieces of information that help drive that. Goal setting works. Goal setting works best when you share it with other individuals. So people set goals on a weekly basis that they can work on, and they share it within the group. So they are no longer responsible to themselves, they are responsible to the group, and they agree to report on the progress they make on their goals. We work through obstacles and challenges over time. When there are individuals who are paying attention to the person's pain, they're more likely to catastrophize, and they're more likely to focus on communicating their pain to that individual. Which means if our approach was to focus on the pain, we would get the pain in return. And that is our conventional focus usually, focusing on the pain. This group doesn't mention pain. This group mentions re-engaging in life. What can you do to re-engage in your life around those realms of wellness? What choices will you make to get your life back? Now, in the course of doing that, we, of course, will work with their sensations, but we're not focusing on their sensations. We're focusing on their engagement with life, which is critically important. And then finally, when we look at this, we can see that even that pain-related behaviors are persistent. Some of that is because of central sensitization. Some of that is because of social reinforcing networks. And so groups help to provide social reinforcing networks toward resiliency. And I tell you, nobody can read somebody else better than a group member, right? If somebody's giving reasons why things can't be done, we can't tell them that this is not the only reality, but their peers can say, that's not good. That's not good enough. That happened to me. I changed my way of thinking. I got to this place. So we have our intro class. I talked to you about that. We gather data at the beginning of that class, and we immediately start teaching individual skills they can use. We teach them 3 simple movements they can start putting in their life. We teach them a basic anti-inflammatory diet, and we work with them on some simple mindfulness in that first hour and a half visit. And so the intro group is not just about eliciting, receiving, and transferring information. It's about learning skills. The program is about skills development. It's about self-care skills. We have a 9-week program. The way the 9-week program works is we have 2 hours of health coaching around the realms of wellness. We go through each one of those realms and we talk about the kinds of things that people would choose to do, how it applies to their life, how it may apply to their sensation. We don't talk about the pain. If anything, we talk about sensation. And we work to help people differentiate between the idea of pain and sensation and between the idea of pain and suffering. The idea is they're in charge of suffering, and pain is an experience, is an interpretation. And so we do the 2 hours of health coaching, and then we do an hour of skills building. 3 of those hours are movement. 3 of those hours are nutrition, 3 of those hours are mindfulness, and then we include something called battlefield acupuncture, which is a 5-needle protocol in each ear that was done by the DoD to work with individuals who are injured in the field, active military situations. And I'll show you some data on that, but it's very effective. It helps people change the conversation and see the possibility that their sensations can be diminished, but we make it very clear that this is a bridge to a better place. So if a person's not engaged in their self-care, then we don't do anything passive with that individual. If they stop their movements, we stop the acupuncture. Self-care is critical. Acupuncture every day, every week for the rest of a person's life is not sustainable. Self-care is the critical piece. And everything we do is built on reinforcing self-care. So, health coaching components, we work through all the realms. We work through obstacles and challenges, and that's really important. People bring their successes, and we honor them. So important to honor success. They bring their challenges, and the group helps to work through things that could be done differently by sharing what works for them. This is not a fixing group. People don't fix other people, but they share their successful processes with each other. The lifeguard skills are acceptance and commitment therapy kinds of skills, right? We use ACT as opposed to CBT because ACT is a very mindfulness-based process, acceptance and commitment therapy. ACT, it's a kind of psychological approach that focuses on being present in the moment, that focuses on the nature of mind, and remembering that what we know are simply our sensations, what we taste, what we feel, etc. Our interpretations, the stories our mind tells us, then provide context. And if we believe the stories our mind tells us, it can be limiting. And so we work with people to understand the nature of mind as a source of suffering so that they can work to be present in whatever moment they find themselves in. So those are the lifeguard skills that we include. Nutrition, basic functional medicine, nutrition, mindful eating, anti-inflammatory diet, bone broth as critical pieces. We live in the South. Can you imagine? How many of y'all drink sweet tea? That's like an intravenous solution for us, really. I mean, just working, get a person off of sweet tea, and you know how we cook our vegetables? Until they're mush or they wave in the wind, right? And so not very high nutritional value when you cook in that way. So we're talking about a cultural transformation for individuals themselves and for their families and for their communities. It's a huge piece of work, applying basic functional nutrition concepts. And so we really focus on that. The mindfulness and the anti-inflammatory diet, we're looking at largely vegetables, non-starchy vegetables. If you want to say an anti-inflammatory diet, you're looking at 7 to 9 vegetables, servings of vegetables a day, to the degree that a person can do it, whether it's liquid form or whether it's solid form. Reducing your overall meat content so that meat is on the side, making sure that things are not processed, no fast food, no junk food, healthy fats, and generally whole grains or ancient grains. Ancient grains meaning they're generally not gluten-containing grains, so things like quinoa and buckwheat and teff. This is a difficult challenge in Arkansas. We are the #1 rice-producing state in the country. So white rice is a staple. Sweet tea is a staple. Potatoes and meat are staples. It is not necessarily gluten and dairy-free. For some folks, it's gluten and dairy-free. But we don't start by telling people to eliminate things. We start by telling people to, it's very simple, increase their vegetable intake. Now, some of them eventually, in our more advanced classes, become gluten and dairy-free. And the way we discern that is by looking at their history. So early childhood challenges with ear infections, sinus challenges, colic, gut challenges, implies that the individual needs to be dairy-free. And we will suggest that as an intervention for them. And they may have to try it over time. Sometimes they do it entirely. Sometimes they ease into it. When we look at gluten issues, that often is as a consequence of antibiotic use and a person whose diet is very heavy on glutinous substances, which is quite common when you're dealing, with our folks. So, but we don't do it out of hand, gluten or dairy free. It is something that they work into. We have to meet people where they are. And the idea of suggesting gluten dairy free right at the beginning, we would lose them. We would lose them entirely. The idea of eating your vegetables, they remember that that's a message. This is not an unusual message. And so we continue to work where they are. Movement, absolutely essential to reprogram the connection the brain has with our movement. And so this is very slow, very mindful movement. We often ask folks, how many of y'all have had PT? And of course, everybody has. And how many of y'all don't ever want to go back to PT again? We'll get 70% of people raising their hand, because physical therapy, as it's generally done, is much more of a forceful kind of a thing. It doesn't recognize that not only are we talking about dysfunction within the muscle unit, but also within the myofascia, within the fascial unit. And so if we have poor nutrition, no movement over time, our fascia itself will become the limiting factor, and you can't force that into movement. If you force that into movement, then you get reactive increase in your pain, which just reinforces the pain hole. We do physical therapy, but we do it from a yogic perspective. Very slow, very mindful. It is a place of patience. You can't rush it. Now, that's hard for some folks to realize, because we all remember what we could do when we were younger or in basic training. We could force our body to get there, and by God, I'm going to do it faster, and I'm going to force my body to be there. And so coaching people on patience every day, literally for the rest of your life, kind of a practice. That's our movement. Now, once a person finishes the 9 weeks, they are, quote, graduated. We collect our data at the end of 9 weeks, but that only allows them to go into advanced programming. That is when they get to see an individual practitioner for the first time. Most people, by the time the 9 weeks are done, if they have done their work, they no longer need to see any individual practitioner.
Just to be clear, only coaches, not
we have licensed practitioners there. We have, it's usually a coach and an MD or an APN. It can be done just by a coach, but even when we are in the room with them, we are not doing individual treatment, right? We are serving as coaches. Yes, ma'am.
So if they graduate from the 9-week program, how do you know that they're doing well long-term if you're not following them?
We follow them. So graduation is a way of entering into the second tier program. Okay. And we work really hard to activate people during the 9 weeks. We'll use motivational interviewing if they're not engaged. We work really hard. But this is the point at which, if they are not ready, not participating, that we can send them back to their primary care provider. It has happened maybe 5 or 6 times in 5 years. It's very rare. We graduate people into the next set of the program. Now, again, the next set is individual visits and advanced groups. So these advanced groups are things like a detailed anti-inflammatory diet, going into different herbs and spices that they can use, working with more intensity around healthy fats, looking at different kinds of recipes so that people can switch their eating behaviors. So it's a much more detailed kind of approach. We do the elimination diet, which is eliminating gluten and dairy for those individuals who need to do that. We have a group on reducing the burn. Because if you're on protein pump inhibitors, we can't expect pain to get much better if we're impairing how our nutrients are being absorbed. And so we work to get people off of protein pump inhibitors, which means there's an intensive dietary and sometimes different kinds of botanicals that they can use, or teas, so that they can get off their protein pump inhibitors. We have a gut function group that works with IBS and abdominal pain folks. There's a specific intervention called the FODMAPs diet, which again is a food avoidance kind of a diet that we work with those individuals on. We have Living Well with Pain, which is an intensive acceptance and commitment therapy group run by our psychologists and our physical therapists, so that we can understand the thoughts, feelings, memories around sensation, around movement, and help people identify the difference between their sensation and the story about their sensation. We have Rest, Relax, and Revive, which is basic cognitive behavioral therapy for insomnia, associated also with our pharmacist. We have yoga, chair yoga, mat yoga. We have Tai Chi. At this point, they can see the chiropractor They can see myself. I serve as the acupuncturist as well. We have heart rate variability biofeedback, and then seeing the individual therapist. These are the integrative medicine services that we have as part of the program. They can access some of these folks as soon as they finish the program. Others they will access after they have been evaluated by a provider. And those are the more limited resources, right? Chiropractic and acupuncture. Not everybody can receive those. And so we ask those individuals if they're interested when they're doing their work and their tissue is ready to receive that intervention. Does that make sense? If a person is very tight and they're not doing any kind of self-care stretching, you can do chiropractic once or twice a week for the rest of your life, and it's not going to move you forward. If you are actively working to prepare your body to receive the adjustment, it is more likely that the adjustment will actually move you forward instead of just being another method to sort of keep you treading water. We use a review of systems that's based on the MSQ. We found that the MSQ was not very conducive for our population. It was a little too complicated. So this is a brief form. The back page is a basically questionnaire about whole health. So what's your home situation? How many servings of vegetables are you eating? What's your faith like? What's your relationships like? So that in our review of systems, we can not only look at the medically related review of systems, that's traditional, we can also look at how a person is engaging within the framework of their life. This is a schema of how the program looks. The initial core part of the program is this part here. 2 hours of health coaching, an hour, 3 weeks, an hour, 3 weeks, an hour, 3 weeks, and then the battlefield acupuncture. Down at the bottom are the advanced programs that people can continue to work on. People choose those advanced programs. Individual providers, whomever they see, may recommend them, but this is largely by choice. This is the program that people opt into. I'm just going to skip that. We sort of talked about that. So inflammation, critically important. When we deal with pain, as when we deal with PTSD, early adverse events are essential to understand. People with early adverse events, whether that's neglect, whether that's living in an unsafe environment, whether that's MST or any kind of emotional or physical trauma or sexual trauma early in life, can set up a person's coping and resiliency skills forever. And very interestingly, early adversity, more than depression, leads to a lifelong increase in inflammatory markers. And those inflammatory markers, when driven by early adverse events, are blocked by SSRIs. Early adverse events leads to increased inflammation. In our population, we are dealing with a hypersympathetic population. These folks are stressed. They are stressed and they are on guard, even if they don't have diagnosable PTSD. And we know that stress alone increases inflammation. We can't work with chronic pain without working with inflammation. Our folks love seeing this. This is a functional medicine diagram, and they're like, wow. And the message here is there's science around all this. This is stuff that's knowable, and we point out this right here. Insulin, statins actually drive inflammation. That blows people's minds, right? Lots of people are on insulin. Lots of people have high fasting insulin. We're driving inflammation under those circumstances. Working on that, working on optimizing metabolism is essential when dealing with chronic pain. These are just some of the materials that we give people. We try to make it very, very easy and simple so that they understand what to put into their diet. Bone broth is not something we start on every single person, but especially if they have challenges with issues around tendinopathies, with issues around joint capsule or cartilage challenges, we ask them to do bone broth, which is actually very culturally copacetic in Arkansas because there's a lot of wild game that's killed, so there's a lot of bones that are available. Now, talking about mental health. So Damasio has hypothesized how we create our mental mind map. Our mental mind map is the sum total of all of our sensations. It's organized in the insula with all of our thoughts, feelings, and memories. This is how we get emotional content placed into physical sensation. All of this is important to understand as we help an individual work to reframe that mental mind map. And one of the interesting things is that yoga increases the amount of gray matter in the insula. Now, we could jump a few bridges and say, well, maybe yoga helps to reframe the mental mind map. We don't know that by data, but it's an interesting thing to hypothesize about. Meditation works separately from the opioid response. The effect of meditation is not blocked by naloxone. So meditation is an independent, separate intervention. I've been told I have 5 minutes, so I'm going really faster. So this is a functional medicine concept around the idea of fascia. There are many things that determine fascial health. Certainly smoking does. Diabetes and insulin does. Inflammation, nutrition, all of these things are going to be essential to consider when looking at the health of the fascia. We can't deal with chronic pain without looking at fascial health, independent of muscle health, of muscle mechanics. Fascinating what the mechanoreceptors will do in the body. And so if we look here, inhibition of sympathetic activation, especially with lateral stretch and tangential forces. So working with yoga, specifically the lateral movements in yoga, actually induce a parasympathetic effect and inhibit sympathetic activity. We'll skip this. So acupuncture. The whirl is all important. This is work that Helen Langevin did from University of Vermont and Harvard, and now she's the head of the National Institute for Complementary and Integrative Health. And so she did this work saying the whirl is most important. When you laterally stretch or when you whirl the acupuncture needle, you're inducing a piezoelectric force within the fascia. When you put electrical stimulation into that, you are triggering the stem cell. And the stem cells can help remodel fascia. So when we talk about remodeling fascia, we're talking about yoga, we're talking about acupuncture, we're talking about deep cross fiber stimulation called the Graston technique. And so our physical therapist works as a fascial remodeler. Battlefield acupuncture in the moment of that visit can reduce pain scores by 3 points, which can change the nature of the visit. Work to reduce from 6 to 3. It'll work for about 87% of folks in the moment of doing it. This is data that we have on our personal health inventory, where you are and where you would like to be. And what we see is from the beginning of our group to the end of the 9-week group, people will assess themselves to be at a higher place. They will assess where they are to be at a higher place. And what we didn't expect is that they will see more possibility to be better than they had hoped to be when they started. So both where they want to be increases and where they're at increases. And this is a measure of seeing whether or not a person is getting back into their life. So this is just the graphic that we have. This is our team. Our team has about a total of 5 forward-facing FTEs. Now that takes out their administrative time. Those 5 folks run 29 groups a week. Those 5 folks run 29 groups a week. Highly efficient. Make only changes that the patient suggests. This is not a paternalistic process. We don't tell people what to do. Now, our challenge is sometimes it feels frustrating, right? Because we'd like to tell people do this whole long list of things, and we expect that it's going to be done next time we see you. And if you don't do it, well, you're non-compliant, right? So we don't have a lot of non-compliance because people choose what they're going to do. And then they are successful in having done that or more by the time they return. The challenge is that we need to follow them perhaps more frequently than we would otherwise follow them so that we can continue to coach them into a more full representation of what could be done. And that's one of the reasons why groups are essential. So I just wanted to show you our space. This is our Integrative Medicine and Wellness Center. We have a wing of the hospital. I'm sorry that I don't really know how much the square footage is. I think it's less than y'all's square foot, having walked y'all's space yesterday. We have a teaching kitchen as part of that. It's essential to reteach people how to actually cook. And this is where all of our providers are. Let's see, that's the next one. There you go. This is our yoga room, which also serves as our Tai Chi room over here. This is our waiting room, which is also our education room. We can move the tables if we need to do high or greater Tai Chi classes. There was a case, but I think that I'm out of time. So I want to thank you all very much for your attention. It's been my pleasure. She said, do I have time to do it? Okay, ask questions if you all have questions. Yes, sir.
Are there any exclusion criteria to the impact of like certain comorbidities or certain things per day?
No. Initially, we started off that way. We started off as just being open to primary care and having a 75 MEDD limit, but now it's open to anyone who has the experience of chronic pain. This is chronic non-cancer pain, so that is the only exclusion. It's chronic non-cancer pain. They can come from any referral source across the facility, whether that's mental health or a pharmacy or PM&R or geriatrics or primary care, wherever the individual happens to find themselves. The individual provider who suggests the consult is supposed to let them know that they're going into an active place that is so critical. We see that passive coping propagates pain behavior. It is active coping where people are doing things themselves and not waiting for things to be done to them that actually re-engages them with their life. Yes, sir.
So two questions. The first is what percentage of people do opt in after that first,
Yeah, we'll bring about 20 to 30 people in. The max that we bring in is 30 people. Usually we have 5 or 7 people who opt out. So it's pretty high.
The second thing is, this seems like a great model for just about any health problem. So
You are correct.
that, do people, I don't know if you've studied it or just seen anecdotally, decreases in weight loss, diabetes medication, other medications that feel more needed, more improvements.
That is exactly what happens. Yes, because this is not focused on pain as a thing outside of the entire condition. So we work on bringing people back to their place of resiliency. Again, those realms of wellness are the same as the bottom of the matrix. These are health skills. If you bring a person to their health skills, then you reverse chronic disease. This is about reversing chronic disease, and we do see that. This and then you. Yeah.
About how many patients per group, and also to know if you guys see patients on the weekends?
We don't currently see patients on the weekends or the evenings. That will require changes in tour, and so we don't currently do that. Patients per group, we try for the intro group up to 30. For the other groups, we will schedule anywhere between 10 and 20. For our main program, we'll schedule 20. For the more specific groups, we'll schedule 10. We expect somewhere between 60 and 70% of folks drop out over time, which is pretty traditional for group-based visits. We're just a second.
As mentioned before, this is very model for issues. Expanded the mental health disorders, chronic diseases. And with that, are they looking to expand other locations?
There are other people within the VA who are looking at this model. It is a model that is expandable for any condition and for pain across the system. I mean, it's highly efficient. We have 5 FTEs. We do 29 groups. We can get veterans in. There's basically no waiting period for the way that we roll through it. When we first started, it was an individual-based process. This is after many iterations of continuous quality improvement. And we had a very long waiting list when we first started, which is not acceptable. And so we had to shift our process from an individual-based process into a group-based process. It was to our great surprise and joy that we found that after that group-based process, it was common for people to come back when they saw the individual provider, myself or an APN, and say, I don't know why I'm here. I am so much better. I don't know what else you're going to do for me, right? Now, very often there are things that can be done, but it's not because they need it, Mark.
There are a couple of points that we've talked about before. I think are important. One is that many patients go through the initial programs don't need to see a provider after.
Yes.
They're about half.
Mm-hmm.
And the other is that you're not focused heavily on supplements or labs. It's really the bottom of the matrix.
Oh, let me say that very clearly. We do no labs. None. I mean, regular labs, right, that you can get from anybody. We do no specialized testing. Zero. None. And supplements within this system are limited to fish oil, lactobacillus, melatonin, and minerals. And vitamins, yeah. And that's it. Now, we can suggest to our folks that there may be some supplements that would be useful for them, but most of our folks don't have the resources to get them. And so we don't even suggest them. We ask, do you have the resources? And if they don't, we don't put it on the list because it's pointless, right? So everything has to be done through nutrition, through mindfulness, through movement, through rest and recharge, through those resiliency factors at the bottom of the matrix. That is the richness of functional medicine. The richness of functional medicine is getting out of the idea that we're going to chase a symptom and into the idea that we're going to return a person to their place of resilience, and by understanding the dynamic complexity of interactions that ultimately create that symptom and other symptoms. Did you have another point? Yes, sir. And this will be the last one, and we'll have to wrap up.
I'm wondering if you have any experience the financial aspect of running this program.
So yeah, we have done that. So for the 9-week program, if it is run by a health coach, because it doesn't require an LIP, a licensed independent practitioner, if it's run by a health coach, that 9-week program costs $939. Does that blow your mind? Yeah, it should. It's a very low cost to run that 9-week program. For the total program. Yeah, for the total program for the 9 weeks. Not the advanced programming, just the 9 weeks. Mm-hmm. So we've started the maintenance group. The maintenance group is run by peers. Peers are veterans, so that they can share a veteran experience. We train the peers as coaches. Those individuals run the maintenance group. They work through the circles of health again. They reinforce the movements, the nutrition, and the mindfulness so that people can continue this place of having someone help keep them on track. But the peers are the most cost-efficient ways of doing that. Thank you all very much. It was my pleasure.